Hello friends, today I am talking on fetal myocardium and related diseases, their prenatal diagnosis and significance. First we will talk on fetal myocardial development and its functions. As we all know, heart develops from tubular structure which by process of looping and torsion evolves in four-chamber structure. All fibers of embryological heart are arranged radially, whereas adult heart is wholly anisotropic, that is directionally dependent of both electrical and mechanical functions. Besides being arranged in two layers, the fibers undergo toroidal rotation within layers for transition from spongy two-layered meshwork to distinct three-layered structure. The inner fibers are more longitudinal. They become transverse in middle part to return progressively more longitudinal in outer part, that is toward epicardium. Thickest layer is middle layer arranged circumferentially is responsible for pumping action of ventricles. Myocardial maturation begins early during fetal life and completes late in fetal life. This architecture of heart may change in congenital and acquired heart diseases. In congenital heart diseases like pulmonary atresia with intact IVS and aortic stenosis, the subendocardial ischemia and fibroelastosis play a central role in loss of functions of left ventricle. Myocardial fibroelastosis replaces endocardial longitudinal layer and increases the stiffness of endocardial layer. This process results in restrictive pattern with end diastolic pressures raised. During cardiac adaptation, changes in cardiac functions as well as changes in heart shape and size can be determined. These changes are the heart's attempt to adapt to insult, a process known as cardiac remodeling. Functional echocardiogram is helpful in diagnosing and predicting harmful and long-term cardiovascular outcomes. Images in 2D are used to perform measurement of most cardiac dimensions such as atrial and ventricular size and valve diameters. Conventional Dopplers can also be used to obtain information of ventricular blood flow both systole and diastole as well as calculation of time periods. Now which cardiac functions to be assessed? These are cardiac biometry, cardiac diastolic functions, cardiac systolic functions which include cardiac output, MPI, shortening fractions, MAPSE-TAPSE and finally cardiovascular profile scores. For biometry, we can check cardiothoracic ratio, which is cardiac area divided by thoracic area. Both are measured by ellipse method. Refer points for heart are cardiac apex and upper edge of atrial septum, and for thorax, anterior thoracic wall and posterior edge of vertebra, including the ribs. CT ratio shows modest increase throughout the pregnancy, that is 0.20 at 18 weeks to 0.28 at 41 weeks. Likewise, cardiac sphericity index, it is measure of transverse diameter and longitudinal diameter. Cardiac transverse diameter is measured just below the AV walls from outer to outer at greatest dimensions, while longitudinal diameter is measured along cardiac axis marked by line equally dividing the IVS from base to apex. Cardiac sphericity index is longitudinal upon transverse cardiac diameter. It remains fairly constant throughout the gestation, that is 1.24 at 18 weeks to 1.17 at 41 weeks. For wall thickness and septal thickness, entire heart with both ventricles as well as IVS thickness are measured at the maximum size during end diastole confirmed by full dilatation of ventricles during closure of AV walls. IVS thickness normally 3.5 mm during second trimester, 4.5 in third trimester, and if more than 5 mm it is considered abnormal. For atrial dimensions are obtained at their maximum size during end systole prior to opening of AV walls. Both longitudinal and transverse diameters can be taken by lines dividing atria in 4 equal compartments while atrial area is measured by manual tracing along the inner myocardium. Similarly, ventricle transverse diameter measured just below the AV valves and longitudinal diameter from AV valves to the ventricular apex. Area of ventricles are acquired by manual tracing along inner myocardium, including moderator band, muscular tuberculation, all inside the ventricular cavity. Diameter of pulmonary artery and aorta are measured by placing the calipers on lines that define vessel wall in 3-vessel trachea. Now to assess fetal cardiac diastolic function, we use E upon A ratio. It uses AV valve Doppler waveform. In this E wave component represents passive ventricular filling in process of myocardial relaxation, and A wave represents active ventricular filling due to atrial contraction. Pulse rate Doppler volume is put at tips of AV valve leaflets with Doppler beam parallel to the blood flow. It is index of ventricular preload and compliance. E upon ratio is less than 1 in fetus, suggesting that atrial contraction component contributes major blood in diastole. With increase in gestation age, ventricular compliance increases, that is, heart becomes less stiff, and there is a reduction in afterload due to decreased placental resistance, due to which relative contribution of passive filling, that is E part, in diastole increases, which causes increased E velocities, with A part remaining constant, thus increased E upon A ratios. Value of E upon ratio is around 0.53 in first trimester, 0.7 in second, with increasing to 0.82 at term. Higher peak flow velocities across tricuspid valve than mitral valve suggest greater blood flow across tricuspid valve than mitral valve, thus support the concept of right heart dominance in the fetus. Shifting to left ventricular dominance starts in utero towards the end of gestation because of increasing compliance and diastolic performance more in left ventricle than in right ventricle. Abnormal EA waveform can be seen in severe FGR, fetal tachycardias, pathologies like cardiomyopathies, TTTS, structural heart lesion with heart failure. Ventricular inflow waveforms in these conditions become monophasic and shortened in duration. That is, both E and A waveforms get merged in one waveform. Cardiac compression forms intrathoracic masses, and effusion is associated with biphasic flow pattern with dominant E wave. Another way to assess fetal cardiac diastolic function is assessment of different veins like ductus venosus. Pulse wave in ductus venosus with sagittal insinuation shows normally continuous forward flow in triphasic pattern. In diastolic dysfunction and in FGR, there is A wave is absent or there is reversal. Pulse wave in umbilical vein normally it shows non-pulsatile flow which become pulsatile in diastolic dysfunction. Pulse rate Doppler is placed 1 to 2 mm into pulmonary vein from junction with left atrium, shows continuous flow throughout the whole cardiac cycle with systolic and diastolic peak. It changes to A wave reversal in left ventricle diastolic dysfunction. Pulse rate Doppler sampling of IVC and hepatic veins. They with parallel Doppler beam parallel to blood flow allow assessment of increasing E wave reversal and loss of early diastolic forward flow in diastolic dysfunction and FGR due to increased right atrial pressure. Finally, non-immune hydrops develops with skin edema and fluid collections leading to fetal hypoxemia and acute fetal demise. Systolic functions can be evaluated by measuring outflow from both ventricles. First is cardiac output. Abnormality of cardiac output when present are late manifestation of fetal adoption. Diameters of aorta and pulmonary valve are measured by leading H2H method in 3-vessel or respective outflow tract views. Stroke volume of LV and RV is calculated by multiplying VIT of aorta and pulmonary artery to their corresponding vessel areas. Stroke volume increases exponentially with gestation age. For a right ventricle, it is 0.7 ml at 20 weeks to 7.6 ml at term. Similarly, for left ventricle, 0.7 ml at 20 weeks to 5.2 at term. Cardiac output is stroke volume into heart rate. Right cardiac output is larger than left one and it is 55 to 60% of total cardiac output. Cardiac output at term is about 1735 ml per minute. Cardiac index, which is cardiac output divided by effective fetal weight, it is constant at a mean value of about 553 ml per minute per kg. Significance of cardiac output is it is mainly affected by preload and ventricular compliance. With advance in gestation, ventricular compliance is increased, total peripheral resistance is decreased, thus increasing the preload and combined cardiac output. Compliance in fetal left heart increases more rapidly than that of right heart with advance in gestation. Another way is myocardial performance index. It is index of global ventricular function and shows early cardiac adaptation in disease states. It includes IVCT, IVRT and ET. MPA is IVCT plus IVRT divided by ET. Ventricular loading and abnormality of cardiac contractility, that is IVCT, and relaxation, that is IVRT, both affect MPI. It is afterload dependent. It is increased inductor constriction, outflow obstruction and increased placental resistance. MPI varies from it varies very slightly during gestation. It is having mean value of around 0.36 millisecond with range of 0.28 to 0.44 millisecond. IVCT, that is IVCT begins with closure of atrioventricular valve and ends at opening of semilunar valve of aorta and pulmonary trunk. In this phase, ventricular pressure rises steeply with no change in ventricular volume because both AV valves and semilunar valves are closed. Isovolumic contraction time, normally it is 28 millisecond with range of 22 to 33 millisecond. Doppler clicks of aperture and closure of valves can be used to identify time period of cardiac cycle, which provide a more accurate assessment of IVCT and IVRT. Now, isovolumic relaxation time, it begins with closure of semilunar valve and ends at opening of AV valves. It is associated with decreased ventricular pressure with no change in ventricular volume as AV valves are closed. Mean duration is 34 millisecond with age of 26 to 41. Now the ejection phase, it begins with opening of semilunar valve and ends at closure of same. As ventricular pressure continues to rise, it exceeds the pressure within great arteries and semilunar valves open, resulting in rapid ejection of blood. Mean duration is 175 millisecond with range of 159 to 195 millisecond. Left MPA can be measured by applying sample gauge of about 3 to 4 mm over leaflets of mitral valve and aortic valve. Left MPA is equal to IVCT plus IVRT divided by ET. Right MPA is obtained by waveform of both tricuspid valve and pulmonary valve. Both waves in one display are possible only up to 20 weeks. After 20 weeks, distance between pulmonary valve and tricuspid valve increases due to pulmonary conus in between. Therefore, both waveforms of TV and PV cannot be displayed in one. Difference in fetal heart rate should be of less than 10 beats per minute between two Doppler spectrum of pulmonary artery and tricuspid valve. MPI of right side equal to A minus B upon B. Another way to assess systolic function is shortening fraction. It is done by M mode. When M mode beam is positioned perpendicular to ventricular septum and diastolic and systolic diameters can be accurately measured with EDD being the largest and EST is smallest. Shorting fraction is equal to EDD minus EST divided by EDD into 100. Shorting fraction is associated with late stages of deterioration in fetus because they mainly reflect radial myocardial function. Normally, LVSF is more than 28% and RVSF is more than 24%. Like normally we can see EDD is more than EST, and here in HLHS we can see they are almost equal. There is very much less difference between two. Therefore, decreasing the shortening fraction. Another way to assess systolic function is MAPSE-TAPSE. M mode can also assess global longitudinal function in fetus when applied in long axis to evaluate long axis displacement of tricuspid wall or mitral valve relative to M mode tracking line. This is good correlate of ventricular systolic performance. Long axis displacement of AV valve increases with gestation age due to increase in heart size with advancing age. Right ventricular annulus has highest long axis displacement followed by LV and then IVS. Due to longitudinal muscle fiber in RV, it contracts along long axis as compared for LV, which contracts along short axis due to circumferential orientation of muscle fibers. Therefore, this annular plane excursion is more beneficial for right ventricle. And last, cardiovascular profile score. It incorporates 5 categories of USG marker: fluid collection, heart size, systolic and diastolic cardiac function, umbilical artery Doppler and venous Doppler, each with 2-point score. Like for fluid collection, we can check hydrops. If it is not present, hydrops is not there, then this is 2 points. If there is ascites or pericardial or pleural effusion, then 1 point. But if there is fluid in more than 2 cavities or skin edema, then 0 point. Similarly, for heart size, we can check cardiothoracic ratio. If it is between 0.2 to 0.35, then 2 points. If it is 0.35 to 0.5, then 1 point. If it is less than 0.2 or more than 0.5, then 0 point. For cardiac function, if there are normal mitral and tricuspid valve functions, diastolic as well as systolic, like shorting fraction is more or equal to 0.28, then 2 points are given. If there is holosystolic TR or MR with shorting fraction is less than 0.28, then 1 point. If there is TR or MR with monophasic diastolic filling and difference of pressure over time is less than 400, then 0 point is given. In umbilical artery Doppler, if it is normal, then 2 point. If it is absent end diastolic volume, then 1. If it is reverse of end diastolic volume, then 0 point. In venous Doppler, then if umbilical vein and DV are normal, then 2 point. If DV is showing atrial reversal, then 1 point. If umbilical vein pulsatility is present, then 0 point. This CVP score provides a global assessment of severity of heart failure and fetoplacental compromise. Normal CVP score is 10 out of 10. A CVP score of less than 7 indicates high risk of in utero death. Now, while concluding, fetal biometric data can be changed into clinically useful Z scores, which allow us to determine how far a measurement deviates from gestation-specific averages. Z score of 0 means average value for that gestation age. Z score of 2 and above, that is either positive or negative, it means they are quite far from mean. Z score of more than 3 or less than 3 are considered too far from mean, that is potential outliers. To calculate Z scores, we use calculator, probably best known is www.parameters.com. Now we will discuss fetal myocardial diseases, that is fetal cardiomyopathies. These can affect left or right both ventricle, including IVS. It is associated with abnormal cardiac function and subsequent impaired outcome. This can be dilated, hypertrophic, restrictive, ventricular non-compaction, or arrhythmogenic CMP. Arrhythmogenic mainly affect teenagers and it affects primarily right ventricle, can result in sudden death. For dilated cardiomyopathy, we can diagnose by ultrasound. It will show enlarged heart with dilated right, left, or both ventricles. Ventricle dilatation can be checked by cardiac sphericity index or cardiothoracic ratio. Ventricle wall contraction is reduced and can be assessed by M-mode measurement and reduce shortening fraction. Pericardial effusion can be there. Small VST can be seen occasionally. Cardiac failure with hydrops with DV showing end diastolic reverse flow in some cases is first detected sign. Like in this case, we can see there is a large dilated heart with very small area occupied by lungs. There is lung hypoplasia along with cardiothoracic ratio. We can see it is 0.79, which is normally upon 0.3. There is also pericardial effusion. We can see it means it is in last stages. In this case, fetus died after 3 days. In color Doppler, we can see mild to severe regurgitation of walls of affected ventricle. It is with very high PRF. It is around 65. You can see most of the blood is at AV wall. Very little flow is going in lumen of ventricles, or most of the blood is showing regurgitation. This dilatation and insufficiency increases with gestation age and may result in ventricular dysfunction and fetal hydrops and poor outcome. Associated findings in dilated cardiomyopathy can be ventriculomegaly, echogenic foci in liver indicating infectious etiology. CNP can be seen in monochorionic twins and it mainly affects right ventricle. Anemia due to parvovirus or isoimmunization may also cause CMP with hydrops and increase PSV in MCA. Bradycardia with or without heart block may suggest maternal autoantibodies. AV malformation can be seen in fetus or placenta. Then significant cases remains idiopathic. Dilated cardiomyopathy can be primary, that is familial CMP, sarcomeric mutations, neuromuscular diseases, mitochondrial diseases, or laminopathies. It can be secondary due to glycogen storage disease, lysosome storage disease, fatty acid oxidation disorder, inflammatory and infective. Or it can be due to structural heart diseases like valvular heart disease or coronary artery injury. Differential diagnosis can be by dilated right ventricle, which can be seen in Epstein anomaly and tricuspid dysplasia. Bilateral AV wall insufficiency can be seen in myocarditis, volume overload, and other conditions. Left ventricle endocardic fibroblastosis with patent but regurgitant MV is one of the main details. In genetics, we can advise chromosomal assessment including microdeletion 22q11.2 microarray or WS. Gene coding for myosin heavy chain is commonly found. A family history in genetic counseling is crucial and can reveal whether a familial inheritance is present for metabolic and genetic diseases. In hypertrophic cardiomyopathy, we can see in ultrasound enlarged heart with ventricular wall hypertrophy of one or both ventricles. Diastolic wall thickness of both ventricles as well as IVS is increased. It is more than 2 Z score. Lumen of affected ventricle is decreased. Pericardial effusion can be found. AV regurgitation is not as common as in dilated one. An obstruction to outflow or inflow tract can be found, leading to aliasing on color Doppler and increased velocities in pulse Doppler. Associated findings can be hepatomegaly, increased abdominal circumference, and change in liver echogenicities, which are signs of storage diseases which otherwise are difficult to detect in utero. Most common condition found in diabetes mellitus, especially with poor glycemic index. Bilateral renal agenesis or dysplasia with oligohydramnios also lead to thickening of myocardium. It may be due to hypertension of renal agenesis or due to pulmonary hypertension with lung hypoplasia. Hypertrophic cardiomyopathy, often evolving in third trimester, is typically found in fetus with chrysopathies. Noonan syndrome also has been reported with significant persistent nuchal edema. Beckwith-Wiedemann syndrome associated with organomegaly and thick placenta is also associated with hypertrophic cardiomyopathy. In TTT, especially in recipient twin, it may develop hypertrophic cardiomyopathy due to volume overload. In etiology, they can be primary etiology like familial CMP, sarcomeric mutations like MYH7, etc. Secondary causes can be glycogen storage disease, lysosomal storage disease, fatty acid oxidation disorders, mitochondrial disease, syndromic condition that is osteopathies, Noonan. Endocrine cause can be maternal diabetes mellitus, anemia like alpha thalassemia, recipient of TTTS, or they can be renal causes, bilateral agenesis or dysplastic kidneys, and many cases are idiopathic also. In differential diagnosis, ventricular hypertrophy can result from stenosis of semilunar valve or structural cardiac defects. Doppler interrogation of cardiac valve should be done in CMPs. Small cardiac tumors such as rhabdomyoma can also mimic ventricular hypertrophy. In genetics, we can do chromosomal assessment including microarray, whole exome sequencing including specific cardiac or cardiomyopathy panels can also be recommended. Many cases of hypertrophic cardiomyopathy are caused by mutation in two main genes MYH7 and MYBPC3, that is myosin binding protein C. A positive test gives a clear marker to track through family staining. In restrictive cardiomyopathy, it is found in less than 5% of CMPs. It is characterized by almost normal ventricular volume and wall thickness, but with enlargement of atrium. Causes the same as of dilated and hypertrophic cardiomyopathy. In non-compaction cardiomyopathy, it is due to pathologic arrest of endomyocardial differentiation or an excessive intrinsic proliferation resulting in hypertrabeculations. It is rare entirety, often affects left ventricle but can affect right and both ventricle as well. It is characterized by layer of non-compacted myocardium in addition to compact layer, prominent ventricular trabeculations and deep intertrabecular recesses. Non-compacted myocardium is typically found at apex and lateral walls of ventricle, reminding of spongy or primitive myocardium, which normally matures into compact myocardium during fetal growth. But here in this cardiomyopathy, compaction is not achieved and non-compact layer is remaining there. It is usually isolated but can also be associated with other cardiac anomalies. Workup can be done like comprehensive family history, detailed examination of cardiac and extracardiac anatomy, molecular genetic testing, serial assessment of cardiac function and occurrence of arrhythmias, Doppler studies of umbilical artery and ductus venosus for early detection of deterioration in cardiac functions. Isolated non-compaction cardiomyopathy can have a favorable outcome. Now, prognosis and outcome in all type of cardiomyopathy, it depends on underlying cause of cardiomyopathy. It can regress prenatally or postnatally to very poor prognosis associated with fetal demise. Risk of in utero neonatal death increases with occurrence of eye drops, stiff ventricular wall and prematurity. These are the references from where I have taken the content, and thank you so much for your patience listening.